One of the commonest procedures performed around the world is called stenting. It's where doctors open up a blocked artery in the heart, put in a little sliver of metal to keep it open. But there have been allegations that far too many stents are being put in when medications and lifestyle change could do the job just as well, if not better. And in fact, a cardiologist in the United States has recently been suspended for putting in too many stents. So what is the story here? I spoke to a leading cardiologist, Associate Professor David Playford.
Stenting in the setting of a heart attack is beyond question. So nobody would ever argue if somebody came in with symptoms consistent with a heart attack, going straight to the lab, getting pictures and fixing up the artery as quickly as physically possible. In the setting of somebody who comes in with unstable symptoms or even symptoms that have rapidly increased, again, opening the artery up quickly is beyond question. The question comes in when somebody comes in with minimal symptoms or symptoms that are not clearly due to angina, and then looking for narrowed arteries, and if you find one, then opening that artery up. There's no evidence whatsoever that that's beneficial. If anything, there is evidence that that can cause harm.
And then there's this grey area called stable angina. What is stable angina and what's the grey area?
So stable angina is reproducible symptoms with exercise. So,
which creep up on you.
Right. It's due to the progressive narrowing of an artery that comes up over some time, plaque or cholesterol deposition in the artery that can slowly narrow it down to a point where there's insufficient blood going through there at times of stress. Usually there are no symptoms at rest because there's still enough flow down the artery for the metabolic demands of the muscle. But with exercise, that fixed narrowing doesn't allow enough blood to go down there to meet the demands of the muscle, and so that's when the symptoms occur with exercise. So it's a very important symptom with stable angina is that it's reproducible and occurs every time with the same level of exercise.
And what you're talking about mostly is chest pain.
It's usually a discomfort. Even the word pain is not often used. It's often across the chest. It may go up into the neck or the jaw or even the teeth or the gums, and it can sometimes go down the left arm. It can be associated with other symptoms like nausea, a bit of sweating, and often in some breathlessness. But those symptoms are classical, and a lot of people don't have classical symptoms. It is any symptom that's reproducible with exercise could be angina.
So why are so many cardiologists putting in stents for stable angina?
The key issue here is in relation to the underlying anatomy. If you've got stable or unstable anatomy, so if you come in with symptoms that are reproducible and the same every time, or if you come in with symptoms that have suddenly occurred or suddenly worsened, or if you come in with a heart attack, underlying there is still the same disease. It's atherosclerosis. What atherosclerosis is a slow and progressive development of cholesterol buildup within the wall of the artery associated with inflammation. So inflammation is an essential part of the process of development of atherosclerosis. And the artery initially starts out with this thing that we call a fatty streak, which is really just the artery is still the same size. There's no narrowing of the size of the artery itself, or the amount of blood going through is completely normal. But eventually, as this progresses through, you get formation of actual plaque, which is cholesterol deposits within the artery wall that's almost like a semi-liquid form associated with inflammatory cells, and it's almost like a sore. It's hot, it's inflamed, it's almost like it's got a scab on the top of it. And this, you still don't know you've got it. So even though there may be a number of these throughout the body, there may be a number in the coronary arteries, in the arteries that supply the brain, you don't know you've got it. The scary thing about atherosclerosis is that you may not have any knowledge that there is a problem until the first complication, which could be a heart attack, could be a stroke.
And of course, the reason for talking about the underlying causes is that the stent is more appropriate for one situation than the other, yet cardiologists are putting in stents for both.
Stenting is a very effective treatment for relieving angina. But what you're doing by stenting is you're putting in a piece of metal, you're scaffolding this artery. And the scaffolding itself is not an inert substance. It's like a bare metal barrier inside of this coronary artery, and the risk is that you could form a blood clot on there, or that scaffold can get covered over by tissue and get ingrowth. Now, in order to stop the ingrowth, new stents were developed, which are called drug-coated stents. They have this coating on the outside of the stent to stop the tissue from growing back into it. And the trouble with the drug-coated stents is that it was so effective in stopping tissue growing into it that the tissue never grew in, so there was this bare scaffold that was exposed to the blood. And so if you stopped one of your medications to thin your blood, there was a significant risk of developing sudden blockage of that stent and a heart attack. If you've got stable symptoms, if they've come on over a period of time and you've got what we call stable angina, most of the time you don't need a stent. But if you come in with sudden symptoms that have occurred at rest, most of the time you do need a stent.
Again, coming back to criticism of cardiologists, is that they treat the artery and not the person. Because presumably, if you've got one artery that's diseased, you're going to have far more than that in your body, and you'll never have enough stents to be able to stent every artery that's sick in your body. What's the story in terms of holistic care for somebody who's got one artery that's gone wrong?
Well, I think the key thing is that you haven't just got one artery that's gone wrong. In the situation of somebody who comes in with symptoms of some sort, and it doesn't have to be angina or a heart attack, it could be a stroke or a transient ischemic attack, which is like a mini stroke, or some other abnormality. If there's any symptom related to the vascular system, it means the problem is widespread. Atherosclerosis doesn't affect just that one artery and leave the others clean. All arteries will be affected. So that means that whatever the process is that's gone on to develop the narrowing over the lifetime of this individual, we have to address everything in order to slow down the process, and if anything, we try to stop the process from getting any worse in the long term. What has been very clear is that an improvement of weight, an improvement of diet, an improvement of exercise levels do actually make a difference in the long term.
As well as reducing your cholesterol and taking aspirin.
Even if you can get good lifestyle changes, there is very good evidence that long-term therapy, once you've got atherosclerosis, you need the cholesterol lowering and you need the aspirin.